let's see a short video on pulse oximeter. Now, what is a pulse oximeter? It is a device that detects the oxygen hemoglobin saturation in the blood. All right. Now, what is the principle based on which pulse oximeters are designed? So, first one we need to see here is Beer's law. So, what does the Beer's law state? The intensity of the transmitted light through a medium is directly proportional to, that is, the absorbance of the transmitted light is directly proportional to the concentration of substance in the medium. And there is one more law called Lambert's law. Now, what does Lambert's law states? The absorbance of intensity of the transmitted medium is directly proportional to the length traversed by the light in that medium. Okay. So now, putting these two together, the absorbance of the transmitted light intensity is directly proportional to the concentration of the substance in the medium and the length traveled by the medium. So from this we get a formula which includes both Beer's and Lambert's law, which goes like absorbance proportional to concentration and length. Now, to remove this proportionality, we include something called as epsilon into CL. Here, so absorbance is equal to epsilon into molar concentration into length L. Here, the units have to be designed again, which is the concentration is always in molar concentration or mole. The length that is traversed is defined in centimeters. And since absorbance is a dimensionless number, the epsilon's unit should be the inverse of these two, that is molar raised to -1, centimeter raised to -1. Now, with this, let's move on to the next topics, that is the physics based on pulse oximeter. The principle of pulse oximeter is based on Beer-Lambert's law. The physics behind the pulse oximeter is spectrophotometer and optical plethysmography. Now, what is a spectrophotometer? This is the identification of oxyhemoglobin saturations is spectrophotometry, and optical plethysmography is analysis of waveform or using the waveform analysis to identify the saturation using what? Optics. What is optics? Lights. Now, what light is used? LED lights are used. And what two lights are used here? One is red light, which is in 660 nanometers, and another one is the infrared light, which is in 940 nanometers. Now, there is a concept of using this. We have something called as AC component and DC component. This was derived from an analogous to alternating current and direct current. So this would be an alternating pattern and this would be a static component. Now, what does this mean? This AC is the pulsatile arterial blood which forms the main input signal for pulse oximeters, and the constant absorption from tissues or venous blood forms the static or the DC component. Now, coming to the types of pulse oximeters. So there are 4 types of pulse oximeters. So one is transmittance pulse oximeter, and the second one would be the reflectance pulse oximeter. The third would be co-oximeter, and the fourth is transcutaneous pulse oximeter. Now, as the name suggests, transmittance pulse oximeter is the light source and the detector are on the opposite side. That is, the light is emitted from one side from the light source and detected with the detector on the other side. The reflectance pulse oximeter, the light source and the detector are on the same side. What is co-oximeter? This is the gold standard of pulse oximeters. Now, this pulse oximeter can detect oxyhemoglobin, deoxyhemoglobin, methemoglobin and sulfhemoglobin. So this can detect all types of hemoglobins. Now, what is transcutaneous pulse oximetry? So this transcutaneous pulse oximeter is the most common form of pulse oximeter that we use, and this is a type of transmittance pulse oximetry. So what was transmittance pulse oximetry? Where the source was on one side and detector was on the opposite side. And this uses lights in two wavelengths. Already we discussed that, which was a red light with 660 nanometers and infrared light at 940 nanometers. Now there are two concepts that need to be understood. So one is a functional oxygen saturation and the other one would be the fractional oxygen saturation. Now, as we discussed, there are oxyhemoglobin, there is deoxyhemoglobin, there is methemoglobin and there is sulfhemoglobin. All right. Now, so functional means which one of these is functional and useful to us, which forms only this oxy. So the functional saturation would include the oxyhemoglobin divided by the oxyhemoglobin and deoxyhemoglobin into 100%. This would be the functional. Now, fractional, as in what fraction of oxyhemoglobin exists. So as you guys would have guessed right now, that would be oxyhemoglobin divided by all the hemoglobins that exist into 100%. And we knew already like this can be detected only by a co-oximetry. So what does our normal pulse oximeter detect? That is the functional saturation. What are the results that is displayed by a pulse oximetry? So one we see is the pulsatile waveform. So always cross check this waveform. Only if this is correct, the subsequent values that will be displayed by the pulse oximeter will be accurate. And second one, percentage oxygen saturation we know. And the third one, the heart rate. Now, let's see the components of pulse oximeters. A little bit of brief overview we got from the previous slides. Let's just put it into a single slide. Now, the pulse oximeter components has the light source we discussed, which was the LED source. Here only infrared is shown, but we know in percutaneous pulse oximetry we had two LEDs. One was at red light and another giving infrared light. Then next we have a channel through which the medium passes. This is where Beer's law and Lambert's law were put into use. Then we have a photodetector. This is a transmittance pulse oximetry. Light source on one end, photodetector on the opposite end, and then this goes to a microprocessor unit where it gets processed and waveforms are displayed in a display unit. Now, let's come to the absorbance curves. What actually means? Why are we doing with two lights? What is the principle behind it? Now, first let's see. We have an axis here, a graph. So, always when we have a graph, define the axis. Here, the x-axis is wavelength. And what is the unit for wavelength? Nanometer. And the y-axis is absorption coefficient. Now, what was the unit for absorption coefficient? We discussed it was m raised to minus 1 centimeter raised to minus 1. Now, here we have two hemoglobins. As you can see, one is red, which is a general denotation for oxyhemoglobin, and the venous blood or the deoxyhemoglobin is denoted by blue. Now, we can see the oxyhemoglobin has maximum absorbance at infrared, that is at 940 nanometer wavelength compared to the deoxyhemoglobin. Also, the deoxyhemoglobin has maximum absorbance at red light, which is at 660 nanometers, which is far more than the absorbance of oxyhemoglobin. So this principle is used to detect the saturation by shining both red and infrared lights and finding out the absorbance of these lights. Now, this formula for pulse oximeter is a detection called R value. This R value is the ratio of AC was alternating component of red light by direct component of red light divided by AC component of infrared light divided by DC component of infrared light. Now, after this R value is determined, it is plotted against a graphical form where R values are mentioned on the x-axis and corresponding saturation in percentages are mentioned in the y-axis. Corresponding to a significant R value would correspond to a saturation level. Now, this is done through healthy subjects, which subjects were subjected to hypoxia with various levels of saturation, and the values were tabulated and then extrapolated. That's why we tell the accuracy of pulse oximeter below 80%, it is not accurate. Now, a short mnemonic or an easy trick to memorize these would be, just remember this. Oxy takes an IR flight 940, whereas deoxy goes to red carpet 660. So with this, it's easier to know the oxyhemoglobin absorbance at infrared light at 940 nanometer. Here, deoxyhemoglobin, which takes at red light, which is at 660 nanometers. So now we discussed about various other types of hemoglobin as well. So first one we saw was oxyhemoglobin. So again, revise again, oxyhemoglobin was taking IR flight 940, right? So infrared at 940 nanometer. And deoxyhemoglobin was walking the red carpet at 660, right? So that is red 660 nanometer. All right. Now, if you see in this, the concentrate only on oxy, that is this red line and this violet line. There is a point at which they merge or they intersect. What is this point? This point is important because this is called isobestic point. Now, what does this isobestic point means? Here the absorption coefficient is same for both oxy and deoxyhemoglobin at this particular wavelength. So this wavelength exists somewhere between 800 to 850 nanometers. So roughly you can quote this as 805 nanometers in some textbooks, or you can remember it as 800 nanometers. This is an isobestic point for oxy and deoxyhemoglobin. Now, most of the exams stop at this. Few higher exams or even foreign exams try to test the limit, asking what is the other isobestic point. Now, for that, you have to trace these two graphs again back up, concentrate on this violet and this dark red one. So if you see, these two go and intersect at some point before as well. That is also called the isobestic point. So there are actually two isobestic points, and this isobestic point corresponds to somewhere just less than 600 nanometers, or you can take it as somewhere to be 590 nanometers to 600 nanometers, or even say, to be on a broader term, to be specific, 550 nanometers to 600 nanometers. So there are two isobestic points for oxy and deoxyhemoglobin. All right. And this methemoglobin and carboxyhemoglobin will come in the further slides. Now, these are just theory slides added for completion. What is the sites of application for pulse oximetry? Which is fingers, toes, ears, cheek, forehead, tongue, thenar or hypothenar eminence, palm, wrist, lower calf, ankle, and foot. Now, a quick pulse or just important points regarding to pulse oximetry. So if you see skipped beats or waxing pattern, it signifies hypovolemia. Now, what is this waxing pattern? So you can just see, imagine this is a pulse oximeter waveform. It is different from an arterial waveform where you see classic waxing and waning. This is just a pulse oximeter waveform, roughly have drawn. So you can see the peak just comes down, goes up, comes down, goes down. So this pattern signifies hypovolemia. Also, plethysmographic amplitude reduction, which is nothing but the waxing pattern is described. And in this, dicrotic notch would be higher with vasoconstriction. But this part is seen or appreciable more in arterial waveforms rather than pulse oximetric waveforms. Now, what are the limitations of pulse oximeter? Now, this is the most important aspect regarding pulse oximeters because almost always there are questions based on limitations of pulse oximeters. And no matter how much thorough you read, they always tend to confuse with few aspects regarding these limitations. A few limitations which are there, it's understood. But few substances or few modalities does not affect the pulse oximeter accuracies. Let's just see what those are. Now, limitations would be failure to detect. Always categorize your answer when you're talking. So if somebody asks the limitations of pulse oximeter, don't start tell in we cannot detect during cardiopulmonary bypass or when the patient is shivering. No, the answer should always be categorized. Now, first thing, failure to detect scenarios. What are those scenarios? One is cardiopulmonary bypass. When the patient is put on a bypass, there is no waveform. So there is no use of a pulse oximeter. Second, when there is hypotension, when there is hypothermia, when there is hypovolemia, it can lead to inaccuracies. Rather than an exact failure to detect, there can be inaccuracies, but in extreme hypotension, extreme hypothermia, extreme hypovolemia, there will be failure to detect. And in Raynaud's phenomenon and improper probe positions and in cases of low cardiac output. Now, what is the next limitation? When there is interference. Interference from what? From other optical sources. It can be either sunlight or OR light or infrared warmers. We are using infrared lights, right? So the infrared warmers also will be emitting the same light. That interference can happen in pulse oximeter. Now, to deal with this, a method developed by pulse oximeter companies. So we have two LED lights. So one was red light and another was infrared light, and then we have sensors for the same. Now, to tackle this optical interference, what they started to do was, first the pulse oximeter shines the red light alone and the sensor detects. Then the infrared light is shown alone and then the sensor detects. Then both these lights are switched off and the sensor detects the ambient light. And after detecting this ambient light, it cuts off the final values. So the accuracy with this tends to increase. And second interference here is electrical, or which is from electrocautery. And the third interference is motion. That is when the patient has shivering due to hypothermia or ambient OT temperature is too low, or in cases of Parkinson's disease where there are tremors. Now, in cases of dysarrhythmias, pulse oximeter can have erratic performance because it is not able to have a consistent plethysmographic analysis. Then, and it is not reliable in IABP patients. Now, coming to the important part of the inaccuracies of pulse oximeter, which is hemoglobinopathies. First one, let's discuss methemoglobin. Now, methemoglobin, we discussed finding out the R value, which was the AC component of red light by DC component of red light by the AC of infrared by DC of infrared. This R value was plotted in a graphical form. The graphic form is here. So here we have the R values, which is denoted on the x-axis and the saturation on the y-axis. Now, since the absorption and emittance is almost same for methemoglobin, the R value corresponds to 1. Now, if the R value corresponds to 1, what is the saturation? Here it is 85%. That is why in cases of methemoglobinemia, the pulse oximeter almost always shows a fixed oxygen saturation of 85%. Now coming to the carboxyhemoglobin. This carboxyhemoglobin is hemoglobin combined with carbon monoxide, not carbon dioxide. That is carbaminohemoglobin. This is carbon monoxide, that is carboxyhemoglobin. We all know from forensic medicines, carboxyhemoglobin classic, cherry red. So here we have denoted carboxyhemoglobin with a bright red color. You can see the absorption or the coefficient, absorbance coefficient of carboxyhemoglobin is very close to oxyhemoglobin. So the inaccuracy with carboxyhemoglobin is the light source or the detector rather, it would detect the carboxyhemoglobin just as it would detect an oxyhemoglobin, and so saturations can even be up to 100% in cases of carbon monoxide poisoning. So two inaccuracies we saw in methemoglobin, almost always 85% because of R value being 1, and in carboxyhemoglobin it can go up to 100% because it closely resembles oxyhemoglobin. Now let's come to the slides where the important aspect, which of the following does not have any effect on pulse oximeter readings. Now, first one is fetal hemoglobin, which is similar to adult hemoglobin, so there is no effect. Second, what we have is the sickle hemoglobins in sickle cell anemias. This does not have any direct effect. Only thing that happens here is the oxygen dissociation curve gets shifted to the right side. Anemia. There is underestimation of saturation at low hemoglobin level. Why? Low hemoglobin level leads to low oxyhemoglobin concentration, which is detected as low saturation by the oxygen probe. Then bilirubinemia. This has minimal to no effect unless it is severe. Now that concludes the discussion of pulse oximeters.